Healthcare clinicians are becoming more aware about the importance of communication skills in practice and how to try and use them. But common assumptions and errors can occur which can hamper the progress we're trying to make with patients. So what can we do about them and what are they? Well, today I'm joined by Vincent Kortleve. He's an established author and educator in communication skills, as well as being a trained psychologist and physiotherapist. And on this episode, we're discussing just that. What are some of the common assumptions or errors that clinicians make with their communication skills, and how can we correct them? You can find Vincent on X or on LinkedIn. You can find me across social media at BYBrowPhysio. If you find this useful, please do go share it with others. Please do subscribe. And thank you for watching or listening, and I'll speak to you soon. I normally plug the guest stuff at the end, but actually there's something I'm thinking about on the similar topic, because you
Yeah.
do the courses and the teaching. Has what you teach, communication skills, how much different is it from when you started, what you actually teach, the skills and that stuff? How much different is that from when you started to now?
Oh, wow. Yeah, a lot.
A
Yeah,
lot.
that's really a lot. Yeah.
Ah,
When I started, yeah, we just, well, teach the things we thought that would be nice, that would be helpful.
mm,
Uh, and, well, there was a lot of, you could say, simple skills in that, just practicing open-ended question, just practicing summarizing, just practicing et cetera, et cetera. And that developed over the years because of all the evidence that came through us, to
mm,
us, and all the approaches like motivation interviewing, shared decision making, et cetera, et cetera. So that gave a real impulse on the level of communication teaching we did. So our teaching, I think, the content of our teaching became more evidence-based, more solid, um, yeah, more with more background from all kind of really good approaches that are used here and there. Yeah.
obviously you've written your book and there was other textbook. I'm just thinking, even when you started, what were you pulling it from? Was there much papers at the time or books to kind of teach from or off of?
Books, yeah. Well, actually, one of my big inspirations was the book of Silverman.
Oh yes, yeah.
Um, I must think of the English. Of course, I know the Dutch title, but I'm thinking of the evidence-based communication skills or something in that order.
Yeah, I mean the
Probably.
third version I believe, or I've got, is called Skills for Communicating with
Yeah,
Patients.
yeah, that is it. That's it. Yeah, yeah. Well,
Um,
uh, I've read the first edition and the second, and yeah, those were really great resources, and that gave, of course, a lot of insights in the evidence that there was at that time.
mm,
Then there came internet. Um, well, at first, I had to go to special library, university library, for looking at good resources, good papers, and scientific magazines, of course. Later on, it was all available by internet, and yeah, that of course is a big impulse. Meant a big impulse for um, development of communication further on. Yeah,
yeah, so well, speaking of books, I can see yours is over your shoulder as we
yeah,
talk here. Uh,
true. It's always standing there because yeah, it's a good inspiration for me too.
in English, Dutch, and what was the other language? There's three, right?
Spanish, yeah,
Spanish.
Spanish, yeah.
Um, and how was it? 4 years ago now it came out?
Um, I must think. Yes, 4 years. The Dutch version was there a little bit longer,
Mhm.
and the second edition of the Dutch version became translated in English and in Spanish in 21 and 22.
Will there be a third edition?
Yeah, good question. I think, yeah, I think yes, because there is still um, yeah, evidence coming through, um, which can enrich the first edition. Yeah,
Yeah. I presume writing, updating editions is much easier than writing it from scratch.
yeah,
Yeah.
yeah. That will be. But um, I also have to think about that. Will I uh, just update it, or will I change the structure?
Oh.
But
Oh.
no, that's still a question is for me. So um, nothing to share in
We'll
this
see.
podcast further on. But yeah, that's also a question. Yeah,
I mean, the structure of the as it stands. So there's the four main roles. So we have
yeah,
the confidant, the
yeah,
coach, the communicative detective, and the teacher.
yeah.
Uh,
Right.
how long did it take to come up with those order, the kind of the terms and then the order and the
Yeah.
concept?
Well, actually, I borrowed those
Oh,
four roles. I didn't came up myself with it. Borrowed those four roles from a Dutch publication, also translated in English, by the way. Um, Communication skills for psychologists,
oh,
and yeah, I've approached the authors of the Dutch version, and I've spoken to them, and I've said, yeah, I like those orals so very much. I would like to use them, and probably adapt them a little bit to the physio context, and well, do something bigger with it. And yeah, they were all okay with that. Actually, they were very interested, and finally, yeah, they ordered a book. Of course, I gave them one, but yeah, they were happy with it the way I did it. Yeah,
oh,
and
excellent.
I think they because there is so much evidence about communication, and by taking these four roles,
Yeah,
um, that was more or less a translation of the evidence to something more digestible, I say.
yeah, yeah. Yeah, it kind of makes it. Well, people always say simpler is often better,
Yeah,
isn't it?
yeah, yeah, yeah.
It's
Easy to
easy.
understand,
I
and
agree.
yeah, when you talk about teacher, everybody knows. All right, what a teacher is doing: education, information giving. Confident, same. That must go. That must be about the therapeutic alliance, and
Mm,
so those roles are very helpful also in education. Yeah,
yeah,
I
yeah.
use them a lot, of course.
We're going to go through some of the common assumptions that some clinicians
Yeah,
have that aren't always correct. We'll start with the confidant, about building relationship, building rapport. We were meeting before. We were saying like, oh, some people can assume, or sometimes assume, because they have a good rapport with people in real life, they're good at making friends, perhaps, or
yeah,
kind of a
uh-huh.
party person. They sometimes assume that can make it easy in practice with patients. When in real life, that's not always the case. Being a extrovert party person isn't always relevant when you've got Mrs. Jones in front of you at 9 o'clock in the morning in distress.
True. Yeah, indeed. Yeah.
Where have you seen this kind of go wrong, and this assumption that someone thinks that they're good at making relationships and rapport when it's not always relevant?
Um, well, I think uh, what is here, students, undergraduate, postgraduates are often asked to reflect on their communication. Why did you do that? Why did you do that? And one of the things I read a lot, and sometimes I see videos of students, um, and they say, Yeah, I'm a good communicator because yeah, I'm so social with all kind of people. It doesn't matter,
Mm.
um, and I think that is an assumption probably that is lying behind this. That when you are social, you are a good communicator, and you are professionally a good communicator as a physiotherapist, of course. I mean,
Yeah.
um, and I think that's not well. Not always true, because when you use communication as a professional tool, as a valuable tool, um, I think you have to use it methodically. So hey, you have a goal in mind. You have to use it conscious. You have to use it systematically, and preferably has to use it process based. So you have to know what are you going to. And those four, um, that's, well, a much bigger issue than being social with all kind of people, I think, standing on a party or on the street or in a restaurant.
Absolutely. It's a different context, isn't it? It's a different environment and it's a different situation. Um, a pub or a restaurant and the context of that and the emotions involved are very different to,
Yeah,
you know, middle of the day clinic, and someone's telling you about their personal life and they're going to be sharing different things.
yeah.
It's different skills for different situations, right? And
Mm-hmm.
you wouldn't take the same attitude you have and same mannerisms from the weekend with your friends
Yeah,
to then middle of the week. It doesn't. It might help a bit. It's not a guarantee. It's certainly not a guarantee that it will just come across. Especially uh, you might someone who's really confident in very social settings may not be very confident or able in individual, more if we say dis distressing, difficult settings, because it
yeah,
involves a
true.
very
Yeah,
different skill set.
yeah, like handling emotions in some
Mm,
situation, in a one-on-one situation in private practice or in hospital. Yeah, a lot of people, a lot of professionals find that hard to do. Yeah,
absolutely, absolutely.
how should I respond? What should I do? Yeah,
I've learned actually with the emotional conversations. Sometimes I would always just start. I get worried. What have I got to say? What are the right words?
yeah,
And actually, from reading various things, like and experience, sometimes you don't need to say a whole lot
no, true.
because if I flip the script and let's say I'm the patient seeing the physio doctor, whoever, and the distress, there's nothing to do. There's nothing they can do about it, right? Right. Then you can't, apart from expecting them to be hopefully empathetic and listen, like you can't, they can't do anything else about it. Depending on what it is, obviously. If they can, great. But if it's a life, it's something that's outside of their hands. Um, I've learned a lot of the times just actually if you could be present and sit in the mud with them, so to speak, and empathize,
Yeah, yeah, true.
enough a lot of the
Yeah,
time.
yeah.
Um,
Just be there and listen.
yeah.
Yeah.
Should we go on to the coach?
Uh-huh.
Because that's
Yeah.
the next of the four. That's number two. We were saying before that about motivational interviewing has become more um, prominent as time's gone on, and there's lots of talk, not just in physio but in healthcare in general, about us trying to be more coaching rather than paternalistic
True.
and
Yeah.
didactic. But there are often assumptions that what coach conversation should look like. So where have you seen some of the coaching conversations not always go to plan?
Yeah. Well, I think one thing with coaching is that yeah, we um, everything is called coaching nowadays, more or
True,
less.
true.
So maybe that's yeah a little bit of problem. Um, and it isn't also the case that a coach is always asking everything
Mm,
from the other person. Um, I've tried to, because more or less because of this, um, I've defined the role of coach more uh, about behavior change,
Mm.
about helping, guiding
Yeah.
your patient in behavior change,
Yeah.
just to to make the context clear. What is this role? What is the task of the coach? So coaching is not everywhere and everything.
Yeah.
Coaching is helping people change their behavior, like doing exercises or doing sports or caring better for themselves or those issues. And in behavior change, there are, well, you could say two main topics, probably more, but motivation is an issue, and motivation in interviewing says a lot about that part, I think, and the doing part, the actually action part of behavior change.
Yeah.
There's also a lot of evidence about that. Um, Using that evidence, that's what the role of coach is about, I think.
You were saying about the questions, and it's not all
Yeah,
about, which I find agree with as well, because I don't know your thoughts. A lot sometimes the generic coaching relies on the person you're coaching knowing the answer, but patients that we see may not always know the
no,
options,
yeah,
and then you
true.
have to kind of suggest, or discuss. And that I can remember the generic motivation interviewing training back did years ago, and you asked just lots of open, what would you feel like this, or how would you feel like this, what would you do, and it's on the assumption that they know their solution, so to speak.
Everything. Yeah, 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 yeah,
Is their
yeah,
role, do you think,
true.
for where they don't know the answer or they don't know what can help, for then
Yeah,
having to uh, gently intersect or suggest some things that might help, that we think
yeah,
would help?
yeah, yeah. I think my opinion is that coaching is exactly about that part also, suggesting by doing uh, more reflective questioning or reflections, um, just to help to guide someone um, move on a little bit, and then it, well, probably becomes more clear, just to give him a little bit time, to give him maybe some words to chew on,
Mm,
and then so only asking open questions and leaning back. uh, that's something often is said. Well, probably is not always helpful enough. You have
mm,
to also to guide people. So, I've had some training of Steve Rolnick, the founder of motivation interviewing, and he shows that almost all the time, just those really brilliant and helpful reflections during a conversation helps someone to to move on a little bit, just step by step, little by little, um, at the pace the patient wants, not we.
yes,
Probably also important.
yes, it needs to be meet them where they're at, so to
Yeah,
speak.
yeah, yeah. Nice said.
Do and on the similar vein, as you say about, it needs to be at their pace. Sometimes people aren't always ready,
Yeah,
um, and that's okay. We can't force people to change, of course. It needs to
exactly.
be the
Yeah,
right time for them. Um, but we can obviously, if we're not taking a coaching role, we can into this telling, it then can kind of turn it into a bit of an argument.
yeah,
Um, but no, I mean, my phrase is no doesn't always mean no. It just made something no suggest something different. Um, where have you seen when you've about resistance and someone's not, you're trying your motivation to you're trying your coaching, work with their values, etc., but they're
yeah.
just not quite going along with it's not quite working, and it's not the right time. Again, where have you seen that gone wrong when people try to manage this?
Well, I've recently did it wrong myself,
Yeah. Oh.
more or less. Yeah, there was a young man, really fit, sportive guy, 30 years of age. Um, and yeah, the probably issue was that he was expecting a quick fix from me. Um, and yeah, just tuning what he was expecting and how I saw things and trying to connect those.
Mm.
I didn't well enough. So probably our expectations weren't matched, but yeah, differed too much. And then yeah, probably became a little bit frustrated about his wish to have a quick fix and just move on. Um, so yeah, um, those situations we have, I think, all the time. And
Yeah.
well, there are times when I manage them, well, I think quite well, and the patient is happy, I'm happy.
Yeah.
But that was not this time. No, actually, not at all. I don't have this often, happily, but yeah, it happens.
It does.
It happens. Yeah.
It does. I'm thinking about, as you were saying there, like you, I presume in that example, the quick fix was not going to be achievable. Um,
No.
but I've had this with other experiences, whether it's wanting the quick fix, whether it's having their feeling of what's going on very structurally focused, even though it's not right, or wanting something that's not going to, it doesn't always mean, sometimes we get frustrated by that, but actually their beliefs have come about for sometimes, just normal, natural human feelings of I would like to get better, or it
Yeah.
may always make sense to them, you know.
Yeah. Yeah.
They're not doing
Absolutely.
it out of spite or to be difficult. It
Yeah.
will make sense to them why that's feeling thought is there.
Yeah.
Um, and it's as you said earlier, like if it's not the right time, that's fine. And if you can meet them where they're at, then great.
Yeah, but sometimes that's a challenge. And
Yeah. Yeah.
one of my colleagues, Edwin, that a Dutch physio, um, um, he sometimes says you are not born with perceptions. You are not
Mm,
born with convictions. So um, these are formed on the way, and
yeah.
patient who has these sometimes strange convictions or certain expectations doesn't do this to sue you or something, but
Yeah.
yeah, it's just what he thinks.
Yeah. I always tell people try and find out where did the belief, whatever
Yeah,
the belief is, come from.
yeah, yeah,
You
true.
know, what's the source? What's the source? Because they may not know, but was it them? Was it they told? Was it their own belief?
Yeah,
I had someone tell me very recently that, you know, they didn't want to do lots of lifting because they're worried um, a completely separate medical issue would make it worse. They
hmm,
hadn't been told at all,
no,
but it's just the belief that they'd formed. They just assumed from,
yeah, because of probably their experience.
yeah,
Because when you are lifting and it hurts, that's one and one is two,
yeah,
right? Then
yeah,
you think, yeah, then you think, of course, oh, yeah, then lifting will be bad. And it's probably something that's in society more or less a perception that well, you have to be careful with lifting.
yeah, yes. Well, hopefully we're getting better at it, and there's better
Yeah, yeah,
messaging compared to
yeah,
previous.
yeah.
So I presume the communicative detective is about gaining information from the person.
Yeah, but
Uh,
also talking about these perceptions from the patient.
yes.
Uh, be interested in it and handling them well. And sometimes that's a really challenge, but well, um, some perceptions are, well, in our eyes, in our head, are quite strange things
Yeah.
a patient says, but um, yeah, um, you you must not do something with that uh, thought in your own head. You just have to listen, acknowledge these perceptions, be interested in, curious. Um, so listening to all those perceptions and asking about it and reflecting on it will help to make this more clear. Um, Probably a little bit also from where it comes from and why is it there, and well, must we do something with it? That's also one of the jobs from the communicative detective.
Mm.
And we when we have, yeah, about the word communicative, maybe it's good to say something about that. You can be a silent detective, just asking questions and make some interpretations, but not telling what you interpret. Do we
Interpret.
say that
Yeah,
well? Yeah,
yeah, yeah,
yeah. Um, and I think it's helpful for the patient that you are communicative also about that part of your thinking,
yeah,
your clinical reasoning process. Um, well, just try to open it to the patients here and there.
yeah,
Uh, Taking with you about your thoughts about what the patient is telling you, um, not as this is how it is,
mm.
but more in a, well, in a considerational way, I should
Yeah,
say.
yeah, definitely. And I think it's part full of the guidelines are full of, talk as you're doing your objective assessment, you can kind of talk them
Uh-huh.
through what you're seeing.
Yeah,
Especially, I often say for neurological examinations, you can kind of, as you're doing it, you can kind of say, well, we can say, oh, good, no numbness, no major weakness, that's good.
yeah,
You kind of
true.
talk people through, and sometimes they'll often clock on. Like they'll be able to tell if your testing strength from one arm is weaker than the other. They'll tell. They'll
Yeah,
see that.
yeah,
Um, they'll be able to see that if they raise their arms so far, and then if you do it for them, it goes a lot further. They'll see that. They'll start doing their own reasoning as well, I guess, won't they? To a
yeah,
degree.
true. Yeah, yeah.
Can I ask you about? We were talking about this when we spoke previously. But with open and closed questions, you gave a story of someone who said they were addicted to closed questions.
Yeah, one of my participants in one of the courses I gave, and that was in the second day.
Mm.
Most of the time, we keep some time between the two course days,
Mm.
and so after the first course day, she um, got to a practice and tried to, well, to do the things she learned. Um, and she, yeah, more or less came to the conclusion, yeah, it looks like I'm addicted. I, it looks like I can't ask an open-ended question.
Mm.
And there's, of course, something underneath this. Uh,
Yeah.
there's a more or less, uh, and we talk about that, of course, too. Something like an attitude under it that, um, yeah, you find it, uh, well, a little bit anxious to to give the patient this, yeah, to let him tell his story or to let him make his own answer and
Mm.
not just fill it already a little bit in. Uh, that was, yeah, that was underneath it with this physio. Yeah, and she, well, got working with that attitude. She discovered this and tried to change it. Try to, yeah, um, put more in the hands of the patient and let go herself. Yeah.
Yeah. I mean, we talk about benefits not just for motivation interviewing, but the benefits of open questions, that they can feel
Yeah.
more empowered, they can get more of an answer. It's not so yes, no. Um, but on the flip side, if someone's addicted to closed questions, could it go the other way? Could you be addicted to open as well?
Well, I've never met someone who said that, but um, no, I think that's too strong, probably. But um, they're both helpful.
Hmm.
Closed questions, open-ended questions, um, they have their goal. And
Yeah.
when you want to know what the patient really thinks, and you don't want to suggest something, like in the question, "Do you have pain?" Um, then you are suggesting that there probably could be pain only by mentioning the word.
Yeah.
Um, So doing a provocation test and asking, "Do you have pain?" is not really a smart question most of the time. Um, Probably that is a circumstance that you better would ask, "How is this?"
Hmm.
Um, Something like that.
Yeah.
So the patient has to choose his own words, choose the words for the things he is experiencing at that moment. Then the answer is more valuable, I think.
Hmm.
But there are, of course, a lot of moments that also the closed questions are absolutely fine.
Yeah.
And sometimes they even, um, yeah, well, do you sometimes experience stress? No, the patient says, yes. Well, tell me about it. It's probably also uh, an easy way to talk about stress, starting to talk about stress, um, and it's absolutely okay, I think.
Hmm. Yeah.
But that was a closed question first, and then open questions later.
Yeah. Yeah.
Tell me about it. Yeah, actually, is more or less an open question, I think. Of course, talking about the perceptions of patients and the pain perceptions, yeah,
Yeah.
I think, well, most of the times open questions are more helpful then.
Yeah.
Just to let, yeah, also let the people form their own words, choose their own words, and that process, that deliberate process inside somebody is, yeah, you feed it more or less
Hmm.
with an open question.
Yeah. And to think the role of whatever the role of the person is, it may not be someone with they're treating someone with pain. It may be something more specific because pain is very subjective, obviously, and various
Mm,
factors influence it.
yeah,
But if you're in a different role, perhaps looking at something that's much more, dare I say, structural, biomedical, closed questions may be more convenient and more useful, just as suitable.
yeah,
If you're more didactic, if it in that approach, especially
yeah.
kind
Is
of
it there or is it not?
yeah, exactly, yeah.
Yeah, yeah,
But I completely agree. There's a time and a place for both. Like your past medical questions, you can just get yes or no answers out of them.
yeah,
Um, Anything that you just need, basically a simple answer. Well, if you're looking for more depth, I
yeah.
guess is the way to phrase
True.
it, the open questions and can gain more. And I often tell people you'll start open, then you might get closed, but often you'll get open again.
Yeah,
Especially because you're going to motivation interviewing, you're not going to it's to keep closed for motion interviewing. Obviously, you're going to stay open questions. So you start open, get more closed with the specific problem, and then once it comes to discussing it and then making a plan, more open again. And then that can become closed again as it gets more specific. It needs to be kind of like in a cycle, I guess, but doesn't it?
yeah. Well, I think that is actually becoming competent in communication skills. That is that you develop this feeling
Mm.
for what to use when.
Yes, yes.
Uh, and well, there are more or less some rules you could say about this, and yeah, you start using those rules and develop your feeling more and more. Um, and then, developing also your own style of questioning, because that is also, I can, some questions I use, um, well, they probably sound silly when my colleague uses them. And when I use his questions, I don't think, oh no, I would ask them in a different way. That doesn't, um, yeah, I don't like this question. It doesn't, it fits, it doesn't fit me, you know?
Yeah.
Um, so that's also okay. Yeah.
Yeah. It
But you
needs
have
to.
to, keep in mind, all right, is this something that I have to let the patient think about himself, or can I suggest a little bit this or that?
Mm,
Um, and what gives the most valuable answer?
yeah. 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 Absolutely. Absolutely. The final part is the teacher,
Yeah,
which yeah, I presume is about the I say giving information, but the discussion and making the helping them understand or guiding their understanding, if we call it that. A big assumption we were discussing last when we spoke before is assuming that the messages we give to patients is actually the one they take in.
yeah,
I think most people listening to this will, whether it's an exercise, whether it's well, it's medication, whatever it is, you'll suggest something. You'll meet the person again, and you'll ask them, okay, what have you been doing? And they'll do something completely different to what you've been suggesting. Or we may make a discussion about what's going wrong, what's the problem is, and then it seems to have landed. And then you meet them next time, and they say something different. Um, Talk to me about that, about how what we assume that what the information we're giving is what's taken in.
yeah. And they remember,
Yeah.
but they don't.
No.
No, no, there is a recall problem in a lot of information that we give to patients. Yeah,
Mm,
and um, well, probably the teacher should guide also a little bit more. Only this guiding looks a little bit different, and I often use this push and pull approach. I'd say a lot of teaching is most of the time done in the push approach. We tell them, we convince them, we press them. Um, but yeah, the recall will be better when we more use the pull approach. We just try to elicit, evoke this information more from the patient by, just making think, just asking him a question so he comes a little bit about this
mm,
topic himself, and um, or showing that something I do a lot in practice is uh, showing a patient a picture, or asking something about an experience he once had, or um, a metaphor or something, and then try to, by starting to question the patient, try to develop this insight, this new knowledge from the
mm,
patient's mind.
yeah.
There are two, there are probably two persons who do this in a very inspirational way. That's Mike Stewart from England, and Peter O'Sullivan. I've seen him working a few times. I will be there this autumn also in London.
Yep.
And yeah, he's also somebody who owns this part, pulling information from his patient. And that is, I think, probably the, the style of teaching we should develop more as physios. Yeah.
Yes, the facilitating, right? The discussion.
Yeah,
Yeah.
that's a good word for it, I think. Yeah, yeah.
And you're right. Yes, I think is it still 20% we assume that they can actually take away from the appointment? I forget the exact
Yeah,
number.
well, the numbers, well, they differ through all kind of researches, but yeah, sometimes it's even much better, 50%.
Oh, right, okay.
But yeah, I know this. I thought it was Canadian research, and there was 30% of recall. Yeah,
I mean, I don't know about you, but the amount of information I give, the give, but discuss and facilitate is
yeah,
less than it used to be. Knowing now that they're only going to remember so much, I
no,
can still record it on their phone or write stuff down,
yeah,
but the memory's not just going to be of minutes you spend discussing the problem,
yeah,
but they're also going to be remembering the half an hour plus you spent with them doing the assessment beforehand and other bits.
yeah,
Um, and I think we have to be mindful that they're only going to remember so much stuff. I even apply this to when teaching students or other clinicians. Sometimes want to tell them everything. So I'll
oh
teach
yeah,
you
of
all your
course,
knowledge and then realize, oh, actually, if they're new to this, there's not, they will struggle to remember past the basics and the bare
yeah,
bones, so to speak. There's a
yeah,
reason why, degrees go on for 3 years or more, because it takes time for people to take in all the information.
yeah, yeah.
Do you think we almost have to be mindful not to over explain and overshare information?
Yeah, probably. Yeah, yeah, yeah. There's quite a lot of evidence, and it says more or less um, too much information, too much detail,
Yeah.
too much jargon, not matching what the patient is looking for.
Mm,
Um, so yeah, uh, these are really few things. Yeah, we can do something about it. We can do really much better at this point, I
yeah.
think. And it's not easy. It's even much nicer to do, to discuss and to challenge and to use some jokes and uh, just to let people learn. Yeah,
Absolutely.
and probably we something we must do also as a physio is using the body to explain things, their own body,
Mm.
and their own movement and their own um, that is really helpful too.
So yes, having oh, what does Peter call it? I want to say lived experience, but that's not the word, but the behavioral experiments. There we go.
Experience, yeah,
Yeah.
true, yeah,
Yeah. Okay. Well, before we get to the future,
yeah.
Vincent, I'll ask everyone this, but what's been one of your hardest clinical conversations?
Well, I mentioned one
Mm.
early on in this podcast. Let's say the quick fix
Yeah.
patient. Yeah, this one is challenging. I heard him. I hear him a lot from um, physios, participants of courses. Um, for me, probably, one of the challenging conversations I've had years ago. That was a woman. She was a running trainer, running coach, and she had well, some pain in her leg. Um, and she, yeah, more or less, this is also a quick fix patient, by the way, but um, she asked me, yeah, just fix this muscle and then I'm okay. And I said, all right, yeah, well, um, we can do that, but yeah, is it okay that I look at your muscle first and do some examination and yeah, you just tell me a little bit of your story. What is this? Well, yeah, can you tell me what actually is the problem with this muscle? And no, just fix this muscle and I'll be gone there.
Okay.
And that was in a period where there wasn't any dry needling or something. So she more or less asked for a massage,
Okay.
you could say.
Yeah.
Um, and of course, I was a little bit, um, I should, I didn't know what to do. But there was one thing that my head was telling me, that is, yeah, you just can't start. You just can't start doing this massage without knowing what is the matter.
Yeah, yeah.
Probably I was more or less alarmed by a case. I think it was 1 or 2 years before this. Um, a woman that was pregnant, um, and she had some thrombotic problems,
Oh,
but also some vague pain in her leg. And yeah, the medical doctor sent her in for a massage. But I was thinking, I don't trust it. So probably with this in mind, um, I was thinking, no, I just can't go in for a massage in this running trainer, running coach. Must know something a little bit more about her story, about her
mm,
complaints, signs and symptoms, doing a little assessment. And then, well, she didn't let me do this. Uh, so, yeah, in the end, she did go away. Um, I was happy. We didn't have a quarrel or something.
mm,
Um, and I often saw her when I go cycling on Sunday morning. I often saw her with a running group,
oh,
giving her one of her trainings, and she waved at me, smiled at me. So probably the relation was still okay.
yeah, yeah,
Um, but this, yeah, it really was a strange situation, strange
yeah.
conversation, and I didn't actually know quite what to do. Yeah.
Would you, if this had happened now, would you have done anything different?
Um, well, probably, um, I, yeah, probably would be more still in control.
Mm,
Um, and well, I would actually, I would also say, yeah, I have to hear something of your story, do an assessment, and I will try to do it as quick as I can. But yeah, before that, I yeah, I can't do something therapeutical.
mm,
Um, so yeah, the 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 red thread of this, I would do more or less the same, but probably feel better about it now than I did then. Yeah,
yeah.
I
Okay.
more or less I had a feeling that I failed, and that, yeah, of course, that isn't a nice feeling. And now I know, okay, this is my, well, more or less my professional standard, and
Mm.
these things I have to do before, yeah, going to a therapeutic approach with a patient.
Although it sounds like the example before that with the pregnant lady, that kind of intuition almost, I don't say saved you, but like, mate,
Yeah,
you know, you
true.
saved her as well, potentially.
Yeah,
Um,
yeah, yeah, because there weren't really red flags. There weren't, but it wasn't. It it just was too vague. Uh, it was just too, well, and more or less it was a feeling and intuition that yeah, I suggested to her, just, yeah, you better go back to the medical doctor and see him, because yeah, I don't know what's going on. I don't really see that this is a just a pure muscle problem or so. Yeah.
mm, yeah, yeah, so interesting. These days, how would you, I'm sure you get asked all the time, but how would you manage the kind of the fix conversation, the quick fix conversation?
Yeah, well, I try to ask. Um, I try to ask in every conversation. I wrote it also in my book. Try to ask in every, uh, especially first consultation. Ask about the expectations from
Yeah,
the patient
yeah,
somewhere in the first minute. What do you
All right.
expect from today?
Okay.
Or what do you expect from this consultation? What are your questions that we have to answer today? And then you will be more or less satisfied and go home.
Mm.
Tell me. So these are more or less my opening questions, you could say, um, before, yeah, I really start the history taking, something like tell me your story, like Peter always does.
Yeah.
Um, but yeah, um, expectations are probably before that. Yeah.
All right. Oh, straight like ooh, almost like a
Uh,
GP appointment in a way. Like they'd say, "How can I help?" Um, you literally expectation from the get-go. Is that right?
yeah, more or less. Yeah. Yeah.
Okay. And what
And
have you
then,
found?
of course,
Go
yeah.
on. I was going to ask, what have you found the benefit of doing that so early because it gets to the point quicker?
Now, I just, yeah, as soon as I can, I want to know um, what this patient wants with this consultation.
Yeah.
Is he expecting that he only have to tell me where the pain is and then he undresses and lies down? Uh, some people start to undress almost in the door,
Do they?
don't they?
Not in ours.
Because no, no, of course, but uh, some people more or less do this because yeah, they've been to a lot of physios
Mm.
in the past, and yeah, they only get massage or something like that, and so yeah, here is the pain. Can you fix it and then move on? So
Yeah.
if that is the expectation from the patient, I have to know, and I have to know it as early as I can, um, so I can try to manage it.
Mm.
Uh, and I hope then I succeed, of course, in trying to manage it. But yeah, I have to know it as early as I can. Yeah,
Mm. Yeah.
of course, when the patient tells his expectation, I also take the chance to tell my expectations or my the way I work.
Yeah. Yeah.
I would like to work. And I ask the patient, well, does that fit? Is that okay with you that we
Mm.
do it that way? I hear your story. We do assessment. I try to come to a good analysis of your problem, and then we make a plan together. Is that okay with you? That sounds well okay and logic.
Mm. Yeah.
Um, and when we have a match there, we can move on.
Mhm.
The quick fix patients, yeah, then you often have more troubles matching.
Mm. Yeah. And sometimes they have to, it might not click, might not be the right person for them. And
No, in the relation, you mean?
yeah. 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 Oh, yes.
Yeah,
We can't bond with
yeah,
everyone, can we? There's people we're not always going to get on with for
true.
whatever
Yeah,
reason.
yeah, no, true.
Before we get to the, well, we've mentioned the courses in the book already, but before we do that, I always like to end asking about the future.
Yeah.
What do you see as the future for communication skills moving forwards? What we may be coming through in the future?
Um, yeah, well, um, the evidence emerges and develops. So, yeah, there will be new evidence about how to do the things we do in a more effective way. Um, well, a nice example is the research from Ian Cowell.
Mm, yeah,
You've
yeah,
had him in your
yeah,
podcast
yeah,
some time ago. That's about reassurance of the patient.
yeah.
That's really helpful uh, evidence, really helpful research. I think there is more to come about these sort of topics.
Mm,
And yeah, of course, that will uh, uh, develop the topic further. Um, yeah, of course, AI will have impact, and
mm,
I hope it will have a good impact. I've seen some examples where RE is used to more or less fill in the electronic patient file. So the computer isn't the most important thing then anymore. The
Mm.
computer listens more or
Mm.
less,
Yes, yes,
taking notes for
yeah,
us,
yeah.
uh, and that will make space for yeah, really talking, really connecting to people, and hearing the stories.
Mm. It's going to
Um,
be interesting
yeah,
seeing. It hasn't come to where I work yet, but it is in other places where, as you say, this AI software basically records and writes it
yeah,
down for you. But that means clinicians will then have to remember how to like actually sit and be present the whole time. You can't escape to a laptop to your computer for time to type things on. You have to be there all the time, really, dare I say, focused.
yeah, yeah,
Um, which for some people may be great, and for others it might make them feel a bit uncomfortable
yeah,
because they can't, hide into their computer at times. Um, but it'll be yes, it'll be, and then we'll have to be more mindful of our body language. That isn't something we've
yeah,
discussed much tonight, but I think that would be something in the future that as we maybe type less, we
yeah.
maybe
I
having
hope
to
so.
think about more. Yeah.
Yeah, absolutely. Yeah, yeah. I'm not really a fan of typing during consultations, so yeah, I try to do it uh, well as little as I possibly can.
Yeah.
Um, but yeah, of course, yeah, I have to do something with the electronic system, um, and probably some other future thing is also training and developing communication skills with physios or
Mm.
undergraduates. Um, AI and VR will probably help there also a lot. I've seen some, well, really promising tools already um, used in training medical doctors.
Mm.
Um, and you use a VR braille, you VR
Oh,
glasses.
yeah, 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 yeah.
Um, you are in a VR environment, and it's IE powered. So you just talk like I'm now talking,
Yeah.
and the avatar, your patient is talking back.
Mm.
I've tested this already with some conversations about lifestyle. So
Yeah.
yeah, there was more or less a motivation interviewing demonstration, and wow, I was impressed. It really
Really?
was. Yeah, it was really wow, almost like a real conversation. Yeah,
Really? Realistic.
really realistic, and that yeah, of course,
Mm.
could help to you can practice and practice and practice again.
Yeah, yeah.
And yeah, nowadays when we don't use these tools because they're probably yeah a little bit too expensive on this moment, but um, yeah, we often use actors or
Mm.
simulation patients, and
Mm.
you don't have these all the time as a student. You only have those, yeah, once in a while you have an actor or a
Mm.
simulation patient. So, but VR and that it's IE powered, yeah, in probably a few years you can borrow a VR glasses and then, yeah,
Ooh.
do practice 1 hour a day. I don't know what you want.
As much as you like.
Yeah,
Wow.
yeah,
Interesting.
yeah, it is.
Interesting. Maybe that could, well, do you think you could do a course remotely in the future? Just everyone on VR headsets, uh, joining in that way rather than having to bounce around the country?
No, not for me. No, I really not the same, but doing those online courses in the COVID period, yeah,
Mm.
I really, wow, I didn't didn't like that at all.
Mm.
I wasn't good at it also, so it's what, yeah, no, it wasn't my cup of tea, and um, it can be a tool in
Yeah.
a course, but yeah, following a course with real people and a real teacher who is, I hope, inspirational and yeah, that is a yeah, there is a lot of value in that. So I don't think we should throw that away.
No, not at all. So the course, people in the Netherlands, any other countries you go to?
Yeah, Belgium,
Belgium. Okay.
next year Switzerland. Yeah,
Oh, excellent. And the book behind you, so it's Spanish, British, not British, Spanish, English, and Dutch. People
yeah,
can buy online, I presume.
yeah,
Mm.
yeah. On the normal bookshops. Yeah.
And anything else you want to promote or plug that I've missed?
No, I hope I've promoted communication, but yeah, you do that much better than I do on social media. So please go on with that, Ben.
I'm
And
sure.
yeah, I was really honored to be on your podcast.
Well, I'm grateful you reached out when it was a couple of months ago now, wasn't it? But we connected on X, where you are,
Yeah.
and LinkedIn. Anywhere else you are, people to find?
No, I have a little English website. Most of my courses are on a Dutch website. That is our company website, but I have a little English website that is, yeah, about more or less about the book and the model in the book and the roles we spoke about. Um, and people can reach me by that website quite easy. Yeah,
Excellent.
Annex, as you mentioned. Yeah,
I'll put all the links below, people in the description, people to click on. And thank you, Vincent. This has been great. It's a great conversation.
yeah. Well, really, thank you again, and it was nice talking to you.
Likewise.